Hello and welcome, everyone. I'm here today with one of my favorite colleagues, Jennifer Kennedy, and we are here to talk about the cross-pollination between CMS's Dementia Guide program, which we're going to tell you more about during our presentation today, and the CHAP Dementia program standards and certification process. And with that, I'm going to let Jennifer take it over.
Hi, Denise. Thank you. I always love presenting and working with you. And, talking about dementia is really something that um, we should be paying attention to. There's a lot of great information out there. And well, our goals for you all today are to explain the CMS guide model to the best of our ability in the time that we have. We also, as Denise mentioned, we want to talk about that synergy or that cross-pollination between CHAP's Dementia Disease Program certification and the CMS guide model. And then we'll finish it up with talking about next steps in case you're interested either in pursuing the guide model and we hope the dementia disease program standards as well.
Both of these really provide a lot of opportunities to improve the care that's going to be happening for dementia patients, in addition to identifying all the needs that are out there.
Absolutely. And, when we look at dementia in today's landscape, there is about 6.7 million Americans just in 2023 who have dementia, and there's a projected 14 million cases to come by the time we get to 2060. So we know that the baby boomer generation is aging out, Denise, and we have a lot of people in the pipeline that are getting older, and we know that getting older has an association with development of different types of dementia. When we have individuals out there in today's Medicare, primarily Medicare environment, many of them are not getting consistent high quality care. It's not coordinated. It's not that they don't have access to it, or maybe it is, but there seems to be fragmentation of that care. And when you have fragmentation, you're most likely going to have poor outcomes for that individual. And what we're seeing with individuals who have a lack of coordinated care are they're bouncing in and out of the hospital, the emergency room, quite frequently, and they're probably using more post-acute care than someone who has good support and good coordination of their dementia. Another thing to consider here is all of the behavioral issues that go along with dementia. We know that there are behavioral health symptoms associated with dementia, depression, mental health issues, and then it's not uncommon for these individuals to have other comorbidities or other diagnoses in tandem with their dementia. So most likely when you're seeing these individuals as well, they're not really getting a good coordination of everything, not only their dementia care, but all of the other things that might be going on. So let's talk about these folks who have dementia. And as that disease progresses, they're probably going to need supervision. I don't know if you know anyone, Denise, who's had dementia or, maybe a family member, but it's something that requires planning, I think, and education, not only for the individual, but more so for the caregivers who are supporting that individual. Mm-hmm. They need help with personal care, financial care. Where are they going to live? Who's going to manage their medications? Who's going to take clinical management of coordinating their appointments? All of those things really fall to a caregiver, and it can be really quite stressful for caregivers to take care of someone with dementia. And what we're seeing now, as these baby boomers are aging out, many of those caregivers also are Medicare beneficiaries themselves. So we have older adults taking care of older adults. And as I mentioned, there are higher levels of stress and depression and overall negativity to try to manage somebody who is bouncing in and out of the hospital or the ER, or trying to plan for when you can no longer take care of them yourself as the caregiver. I think it's really important to say that when we're looking at dementia in the U.S. care continuum as well, that there are disproportionate impacts on people of color, Asian Americans, Native Hawaiians, Pacific Islander populations. So we are seeing health inequity happening in this space as well. So what is the guide model? That brings us to this particular slide where we introduce, I wish we had some like trumpets or something.
Da, 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 da.
There you go. CMS just recently put this out for public view. They have developed an alternative payment model for individuals who have dementia. And this is the really cool part, Denise, is that there is a build-in for supportive services to those caregivers who are taking care of those individuals. So the whole model is really focused on including that comprehensive person-centered assessment and care planning, care coordination, and that 24/7 access for the caregiver to receive support. Now, that's a support line. It doesn't mean somebody's going to move in with them and be there 24/7, but there is respite care that is built in and paid for by this model. CMS developed this payment model, and it's fair to say right now that it is a demonstration model. It's an 8-year demonstration model to really test whether it's viable or not, in its current state. And it doesn't mean that, once a demonstration model gets going, CMS wouldn't sort of tweak some of the parameters or content after maybe year 1 or year 2. They may tweak it as they go. But overall, the goal here is quality of care, quality of life, and improvement of both of those items for individuals that are living with dementia. So CMS is looking to address behavioral health and their functional needs, and that really good coordination of care so there is less fragmentation, hopefully with a goal of keeping them out of the hospital, keeping them out of the ER and out of those post-acute care settings. And also, keeping them in home where they probably want to be for as long as they possibly can. I did mention there is a build-in for support of that caregiver. So reducing the burden and strain on those unpaid caregivers is really huge. And I applaud CMS for building that into this demonstration model because it is quite stressful, and people get burned out from caring for a loved one with this particular diagnosis. So what are they providing for that caregiver? They're going to be providing skills training and referrals to community-based social services and support, and also 24/7 access to a support line as well as respite care services.
I was really excited when I saw that component in the model because I think that we clearly see when you get caregiver burnout, then some of those outcomes are going to be the exact thing we don't want to have happen, right? Hospitalization, post-acute care setting use, those type of things. So it is a really innovative piece that's been added into this model.
I really love it. And, like I said, I give them kudos for building that in because it can be quite an impact on a caregiver's pocketbook or that individual's pocketbook, just trying to keep them safe, trying to keep them supervised. And CMS is, actually building some of that in. Also, as I mentioned, it's person-centered care. So if an organization, a provider, is going to participate in this model, they're going to have to assign a care navigator to this patient and their family to help them access services, to help them coordinate services, have an individualized plan of care, to make sure they're hooked up with non-clinical services such as Meals on Wheels and transportation to get them to community-based activities or possibly even medical appointments. So the guide model is really, I love it because it's so community-based. It is attempting to keep that individual, again, in their home or wherever it is that they called home, and hook them up to all the services that surround them and make sure that they have access. Also, another build-in is the education piece. So making sure that caregivers have that evidence-based education and support, they have access to that, such as training programs on best practices for caring with someone who is living with dementia. And also the organizations who decide to participate in this model, as I mentioned, will also help caregivers access respite services, which really will give them those breaks from those caregiving responsibilities that they really, really need. So when we look at that guide model, it's addressing unpaid caregiver needs, it's payment for respite services, it's screening for health-related social needs. So the whole approach is to standardize dementia care delivery for participants in the model. And CMS sets up a framework for organizations who want to dip their toe into the guide model program waters. And here's the framework, and then you figure out how you're going to make it work. As an alternative payment model, CMS would provide a monthly per beneficiary payment to support that particular patient and the caregiver team approach, the collaboration, the respite, the education, etc., the coordination of care planning. All of those things would be delivered, and there would be a flat rate, a per beneficiary monthly rate paid to that provider. And then the model, as I mentioned, is really invested in providing that support to the caregiver who is taking care of that individual. Another piece that I like about this model is that there is a requirement to screen for health-related social needs. So it's not just, it's not just all about clinical things. It's
Yeah.
not just about, hey, what's your blood pressure? Or, hey, are you having shortness of breath? Or, all the things that I, as a nurse, would consider, or many other clinicians out there would consider. I like that we're bringing in that social piece, that social worker piece, where these organizations who are going to participate would be required to screen patients for psychosocial needs and health-related social needs to help them figure out what kind of community-based activities or sources or referrals that these individuals would need in tandem with their caregivers. So that's a really nice, even though it's a requirement, it's a really nice build-in, I think, for
Well, I
sure.
think we're really starting to understand more the impact of those dynamics on health, on our overall health and well-being, right? So it really isn't something we can continue to ignore. And I really just applaud that addition, even though I know there'll be some burden as an aspect of that, but it'll be a worthwhile addition to the standard approach to care.
Absolutely. When I see this, I say, wow, CMS is thinking holistic care. And, as a longtime hospice nurse, that's the approach that hospice has taken for many, many years. And you can't cubbyhole somebody's psychosocial health and say, okay, well, your blood pressure is this, and then we're not going to worry about, what your mental health status is today. Are you upset because your blood pressure is high or low or whatever? We can't tease somebody apart. They're a holistic person. So we have to look at everything. And I like that they have built this in as well.
It's a strong interdisciplinary approach. And you're absolutely right. Hospice care has been doing that for a long time, but this can bring this into some other service line models and really adopt that holistic approach.
Absolutely. And thanks for mentioning that word interdisciplinary, because that's a key component in this model as well, because they actually do use that word interdisciplinary. And when I think of that, I have to think holistic right away.
Yeah.
Another build-in here, of course, we're seeing CMS as of, 2021 with all of their health equity initiatives that they're pushing out from the Centers for CMS, is the build-in for people of color, populations who are underserved. We know that these populations have prevalence of dementia, and that they're most likely not going to have good access to care because for a number of social factors, and which means that they probably would not get a diagnosis as timely as someone who does have better access to care and support. These folks, this population also have many more unmet needs, meaning that they probably have many more diagnoses, comorbidities that are going along with that dementia diagnoses. They have higher caregiving demands and spend a higher share of their family assets on dementia care, meaning that, there's a higher out-of-pocket spend to make sure that, grandma's taken care of, safe, etc. So the build-in here is that CMS is paying attention to the health equity piece of this particular model, and they're seeking, when they're seeking participation of providers, that these providers really actively provide care to underserved communities within this guide model. And CMS will offer a variety of financial and technical supports to ensure that providing safety net providers can develop that infrastructure or framework to be able to support those underserved populations as well as any other population. Also, the model does include a focus on bennies who are Medicare, Medicaid, as well as other supports in the model to help them remain safe and in their homes as long as possible. So what CMS is doing with the health equity piece is requiring specific screenings and referrals as it relates to underserved populations. As I mentioned, they're offering financial and technical support for that development of programs, specifically targeting, if you're serving a community that is primarily Latino or Latina, we have to develop a program that speaks to that population. And there would be annual reporting by a program participant on their health equity objectives, what their strategies are, what their targets are, etc. And when we're reporting, we have to have data. So there's going to be a data collect requirement as well as we're looking at that piece of the model. So I love, again, that, I love that CMS is bringing in health equity to everything that they touch and push out the door at the Center for Medicare and Medicaid. I love that, they've done their homework and they know this is an underserved population. When it comes to health equity, we know that Brown and Black people have a higher incidence of dementia. So this is a good inclusion, I think, to make sure that these folks don't fall through the cracks as well.
I think we've seen health equity be an issue for a really long time, but COVID really brought that to light pretty drastically. So I definitely think it's exciting. And, for our providers, I hope that doesn't sound overly complicated. Certainly, there are some things to navigate with this program in order to meet the criteria, but it's also areas that many of our agencies likely want to break into and better serve, and are really fully prepared to serve those populations. So it'll be a great way in to serve these populations as well.
That's a great point, Denise, because it's not just this model. CMS is, pushing health equity out into fee-for-service Medicare, Medicare Advantage. So it's, oh my gosh, I don't want, this is going to be a heavy lift for me in this model. Well, guess what? You're going to be collecting data in with all the other patients outside of this model, somewhere, if you're not doing it now, somewhere down the road in the near future, you're going to be doing it anyway. So, I think if you've not embraced I need to embed health equity into my strategic plan and I need to educate my staff about disparity, you're already behind the eight ball.
Yeah.
So, to me, this seems completely acceptable for it to be built in, for
Yeah.
sure.
And the other thing is there are sometimes there's, cultural, there's a cultural hesitation to participate with a benefit like hospice or even home health, for example. It might feel invasive to home life, or like something family should be the ones to take care of. And building a program like this could be a way of really demonstrating to those communities the value of those services and the help that really can be provided to a family member that's in need.
Absolutely. This model is designed to be administered upstream, right?
Mhm.
When you have an individual who maybe is just early in their dementia diagnoses or they're progressing through. This is not for hospice. This is for home patients who are needing home health services or home care services or
Mhm.
palliative care services. So this is very much a not hospice, we're at the end of life situation here when you look at applicability to it.
Yeah.
So Denise, why don't you tell us, since this is your area of expertise, about CHAP's Dementia Disease Program certification?
Yeah, I mean, I'm happy to just hit some high notes on this. I really think, like I said, when I saw CMS's notification about the GUIDE program, I was immediately like, how does this align with what we've already developed? And I was really excited to see the work that you did on really developing the alignment between our two programs. And there's obviously differences between the two, but overall, we wrote these standards with the effort to provide a standardized way to care for a patient that has a dementia diagnosis. And just like our other 5 disease programs, with the same line of thinking, right? What do these patients in particular need above and beyond what's already going to be provided by, let's say, a home health or home care provider? So there's already going to be a comprehensive assessment, for example. But with the disease program, participants that have a certified disease program are required to do some additional assessments that are really specific to the needs of that patient and that diagnosis in particular. And again, the goal with this is just like CMS, the goal here for us was to create a framework for a program to be built. So we don't actually tell providers exactly what they need to do in order to meet the standards, but we give them that framework so that they can build out what's going to work for them with the resources and staff that they have on staff to make that work. It isn't excessive, but it certainly has some additional components that are going to need to be worked on and built in if it isn't a program that's already being, participated in by the agency. The standards really help outline that. If someone's building this from scratch, the standards are going to provide them what they need to know in order to do that. I mean, you're going to have to build some policies and procedures around what you do when you are doing intake with a patient that has a dementia diagnosis, for example, what that care is going to look like, different from the rest of the population of patients that you're serving. What additionally are you doing when you're going out and you're going into the home with that patient? Again, above and beyond what you would do with your typical patient population. And then, to the point that we were just talking about, some data and some metrics around how this program is really serving these patients. In order to provide that care well, part of the standards are written to state that all agencies that have a program like this and are assigning staff to patients with that diagnosis do need to have some additional training for that staff. And we don't, again, dictate exactly what that needs to look like. And there's a lot of great resources actually out there for dementia care in particular, but they do need to do something, again, above and beyond their normal orientation process or their normal in-service process in order to make sure that those care providers have some additional training around caring for patients with dementia. We've worked really hard to build these standards with some industry experts and as well as some specialty physicians that we've worked with to build these standards to really ensure that they are evidence-based and best practice, and we have them reviewed annually in order to make sure that the resources we're providing to our customers are up to date. The one thing I do like to share with customers about this is that it is an annual process for certification. And part of that is to make sure that that our agencies that are getting certified are collecting data. It is really important. Again, it's not, it's going to be a requirement for the GUIDE program, but it's going to be important for program integrity in general. The agency is going to want this data, right? It's going to help them ensure that this investment they've made is worthwhile and that it really is improving patient outcomes. We don't dictate exactly what data that needs to be gathered, but we do state in our standards that you have to be gathering some data. And the other piece of the reasoning behind an annual certification is to ensure that that staff that you have caring for this population does have that additional education. And with turnover rates that we've seen so high in the last few years, it's just really important that we have some annual check-in about that to make sure that we're maintaining that standard. I think it's going to really have, just like GUIDE, I think it's going to, a program like this, and marrying these two, it would be a beautiful thing. But programs like these can really help our agencies differentiate themselves from competitors, potentially in markets that are highly saturated, but also to help really build a patient population in certain areas and improve relationships with referral sources that are serving patients like this.
Thanks, Denise. And, I love our standards because they're practical. They make sense. They're not complicated, but they are still seated in evidence-based practice. So I can't get any better than that for sure.
Absolutely.
When we're talking about the synergy between the GUIDE model and our disease program standards, both are person-centered, and that's really an important piece of this. So if we have person-centered care, we are all about enhancing individualized plan of care, interdisciplinary care, and a holistic approach to care as well. And you can see here that not only is it a holistic approach, it's interdisciplinary as well. So really huge synergy between care planning and coordination between our program and the model, education and caregiver support. And of course, there is an eligibility requirement. We have dementia standards, so you can't be a cardiac patient and use dementia standards. We have standards for cardiac patients as well. So a lot of really good cross-pollination. When we look at our program, we put the GUIDE model up against it, we can see that really, they're marching parallel. They are shooting in the same direction, if you will, in terms of goals and outcomes.
Absolutely.
So just to give you an example, I pulled a couple of things just to show you what our synergies do look like. You can see here the CHAP Dementia Disease Program. It's, as Denise mentioned, it's a structure, it's a framework, it's built on standardized processes that we want the high quality needle for dementia patients to go in the right direction. So in order to do that, we have to have standardization and we have to have a framework that is based on clinical evidence-based guidelines. When you look at the guide model, they're also shooting for standardization as well, a standard approach to dementia care, and looking at things like staffing and services for unpaid caregivers as well as the patient, and quality standards. So they're as well as we are focused on quality of care, quality of life for the individual and the caregiver taking care of them. Another good example is care coordination. We have built into our standards that there must be an individualized plan of care that talks about coordination of care with all of the other interdisciplinary team members and is based on the assessed patient needs. And really harnessing the, okay, here's what you need, now let's get you coordinated with the resources that are going to help you with those needs. CMS, again, in building into their program, is very much in tune with not only a good assessment, but also that psychosocial assessment piece built into the comprehensive assessment. And again, getting that patient and caregiver connected with resources out in the community based on the needs of their assessment. So when is all this happening? You're probably thinking. Well, CMS put out a timeline, and they do have a webpage, and we'll give you the link to that at the end of the program. But the model timeline, as I mentioned, is due to run 8 years. And it has really like 2 tracks. So if you have a dementia program already established in your organization, the application period is going to be fall to winter of this year right now. I guess we're in fall now. And then the performance year 1 would be starting July of 24 and would run through June of 25. So what this means is you already have a build-in, you already have a program established, you have a framework, and you would be ready to go by the time the performance year is ready to go in next July. The second track is if you're a new program, meaning that maybe you're thinking about getting something together, maybe you started to get something together as a standardized approach or program for patients living with dementia that you'll be caring for. If you fit into that track, you're still going to be in the same application period, but what CMS is doing is giving you a pre-implementation period, and you would not be starting your performance year until July 25. So they're giving you a whole year ramp up, essentially, to get your program together, to test your program, to see if your program works, to do performance improvement, etc. Either way, when I look at this timeline, Denise, I'm thinking CHAP's program, dementia program disease standards and certification is absolutely applicable to both of these pathways.
Yes, yes. I was thinking the same thing. So if you have an established program, more than likely, even with an established program, you can correct me if I'm wrong here, but you're probably going to want to take a really good look at the guidelines and make sure that the program you have in existence is really going to align with what they have. You may need to add here or there or look at certain things in particular. I would say the same is true if you want to get your CHAP certification. You probably already have you are doing some great existing work. You might need to tweak a thing or two in order to fit in those guidelines, fit with the standards, and meet the certification requirements. But all of that would be pretty doable within this time frame that's allotted for the guide program in particular. And I would see no reason not to do those things simultaneously, right? Why not take a look at both things? And if you need to make a change here or there, do them at the same time versus changing one thing and then changing another thing to meet a different need. Same thing for a new program. Take a look at what guide's going to require and what you're going to have to build out, and simultaneously look at what our CHAP standards are going to require from you and put them together. It's totally doable within these timeframes. We have worked with multiple clients who've built a program from start. We have some great resources available that you can add on to that. We've got some great relationships with some consultants that have built some policies and procedure manuals that you can add in to really help give you a jump start if you're starting all the way from scratch. And you could definitely fit it into this time frame to work on it.
Absolutely. And, whether you're on path 1 or path 2, you're going to need to follow, as Denise mentioned, those requirements to participate in this model. So interdisciplinary team approach, right? There also is a requirement, whether you're on, path 1, path 2, that you have to have clinicians with dementia proficiency. And that is recognized by experience for caring for adults that have cognitive impairment, experience caring for individuals who are 65 years or older, or you have maybe a special designation, certification or experience in neurology or psychiatry, geriatrics, etc. And also, you're going to need to have a care navigator who has gone through required training in dementia assessment and care planning. So CMS gives you the time, whether you have a program, whether you don't have a program and you're just getting going, to get these particular staff members in place so that you can participate in the model when we're go time in next July. All right, so I'm going to pass the baton over to Denise to finish us out today, talking about, again, next steps as it relates to our disease program certification process.
Absolutely. The registration process is fairly simple. You can go to our CHAP Education website, and actually you can just put the product in your cart and check out. If it's something you're, ready to pursue right now. If you're not, it's really something that we're happy to do a one-on-one call, learn more about your agency, about what your existing resources are, and have a little bit more in-depth conversation about what that might look like or what you might need to do in order to build your program out. So you could definitely call or email us to schedule a discovery call with you. We're happy to do that. We do this on agency by agency level. So just, single agencies will do this. We've also done this on a larger scale level with companies that have multiple agencies in multiple locations. So that can, adjust the pricing for that, and we can talk through that on a discovery call. The certification process, unlike accreditation, the certification process is a virtual accreditation process. So we do try to make it as simple as possible to get through. And there's a two-step process. The first one is that we review policies and procedures that are related to the disease program. And then we determine whether or not those are all in place to meet the standards that require a policy or procedure. The second step of that is once those have been approved or resolved, if there's any missing issues, then we set up a virtual interview with some key staff members and talk a little bit more about what the training looked like in order to make sure staff were appropriate for caring for the patient population, and review some of the other components of the program that really require that interview process. The standards were written just like our accreditation standards. So if customers are familiar with our accreditation standards, we try to make it really clear what evidence we're looking for when we're trying to meet a standard. So they really say policy and procedure or interview, what is the evidence that we're going to be, that it's going to have the end result of the outcome in that. So the standards really do kind of outline that process, and we try to make that as simplistic and easy to understand as possible. It is something that can happen. You can register for the product, and it can be over the course of several months, frankly, that this is the certification process happens, depending on how far along a customer is in building out their program. Or it could be something that happens within a week or two if the program is already pretty well built and only a few minor changes need to happen. So it really can kind of move along as quickly or, frankly, as slowly as possible. We do try to complete any certification within 1 year of the commitment date. So whenever the customer is purchasing it, we're going to want to complete that certification within a year. One unique thing about our disease program certifications is that you are not required to be a CHAP accredited customer to get your program certified. So whether you're accredited at all by a competitor, you can go through our program, and we have had customers who've done that, or even non-accredited customers can go through the disease certification process. So we want you to all be CHAP accredited, but it isn't a requirement for this particular program.
Thanks, Denise. So, we have some resources here for you. I've given you the link to the webpage that has multiple resources on it for the CMS GUIDE model. And we also have the link here for the CHAP Dementia Disease Program certification. I think the last thing that I just want to say to all the home health or palliative care providers out there, or anyone who is not excluded from the GUIDE model, please think about participating. Please use our resources to help get you ready. This is, significant. CMS has never done anything like this before. And most likely it is going to be, something down the line that will be in a final format as it relates to care provision. So please participate, because only by participation can we give feedback for performance improvement. So I'll come off the box now, Denise, and I think that's it for me in terms of the plea in terms of improving, your care for this particular diagnosis sect.
Well, I'd echo your statement and just say that clearly we've identified a critical need point for it to have gotten this far in the process. I mean, it's like you said, there's nothing been like this in the past. So I think my plea to providers is to participate from the need perspective, knowing that at some point in time in the future, a family member or loved one is going to need these services, and we're going to need great providers out there to help them along in this path.
Absolutely. Well said.
Thank you all so much. Have a great day.
Thank you. Bye-bye.